Hi everyone, I'm Leila Makarechi. I'm the Chief Operating Officer and Executive Vice President of Program Management at Microclinic International. And before I get into the challenges that we faced at MCI, not the phone company, but Microclinic International, I want to give you a bit of an overview about what it is exactly that we do at MCI. So the title of my talk is Contagious Health and Happiness, and hopefully that'll become a bit more clear by the end why I titled this. But we have a philosophy at MCI that we call Contagious Health, and this Contagious Health philosophy is focused on solving a very, very big problem. So does anyone know what factor or what issue is going to cause 75% of death worldwide by the year 2020? Sorry? Access to water. Okay, this could be one. What if I said that 80% of those deaths would be in mid or low income countries? You might be surprised to find out that the answer is actually chronic disease. So diseases of long duration and slow progression. They can be non-communicable diseases like heart disease, cancer, or diabetes, obesity, or they could be communicable such as HIV/AIDS. Our work, Contagious Health, is based on this basic idea that information and behaviors can spread contagiously. We all know that, videos go viral. Who hasn't seen the Gangnam video by now? I think it's probably safe to say we all own a pair of blue jeans in our closet. Well, in the public health field, we know that behaviors and attitudes affect you. The behaviors and attitudes of your friends and family around you affect you. We also know that negative behaviors like smoking or drinking or overeating can spread contagiously through a social network. So if it's already been shown that these unhealthy and negative behaviors can spread, at Microclinic International, what we're proposing is the opposite. Can we leverage the social networks that naturally occur in every community around the world to bring about more positive and healthy outcomes? So how do we do this? Well, if you start with just one patient in a community, let's say she has diabetes, for example, in order for her to access a microclinic program, she needs to sign up with a group of her friends and family members, her peers around her. That could be a spouse, a child, a neighbor, a relative, whoever it is that she wants to join with. And these different microclinic groups come together in a session where they meet with a community health worker or a nurse, and over time they learn not only how to manage their own chronic condition, but really more importantly, how they can help each other in managing the chronic conditions of their friends and family. And after we've reached a significant amount of these microclinic groups within a community, we're able to change health outcomes in a very significant way. So at the top, you have sort of the standard medical model where you have the patient going back and forth to a hospital or a clinic when they need to, when there's an illness. What we're proposing in the Contagious Health model is that instead, some of the basic information to manage a chronic condition, such as diabetes or heart disease, can be withheld and shared in the community itself, in the social network groups or the microclinic groups themselves, and that information can go to scale even if that community doesn't have access to a really great hospital or very well-trained clinicians nearby. And where do we do this work? Well, we've done it in several different places around the world, and we've run research trials in each place that we've worked to measure the clinical outcomes of our work. One of the first places we started working was in the Middle East, specifically now in Jordan, where we partner with the Ministry of Health and Queen Rania's Health Awareness Society. The project in Jordan is focused on diabetes, and we started with just a few centers in Amman, the capital. Over time, we've been able to expand and are currently working on a national scale-up, 3 regions outside of the capital. Also based in Jordan, we have a new partnership with the UN Relief Works Agency, and we are training the UNRWA nurses who provide health services to refugees throughout the region so that they can provide the microclinic model at scale. In a very different context, we also work here in the United States, in Appalachia, Kentucky, This is the southeastern part of Kentucky. We started working on a project that combines diabetes, heart disease, and obesity, and the pilot was funded by a health insurance company, Humana. Later, we were able to scale up our work there with some funding through the CDC under the Affordable Care Act, and we're working on an even larger scale up right now throughout Kentucky with more support from Humana. Oops. We also have found the model to be successful for communicable disease, such as HIV. So our HIV project is located in Kenya on a little island in Lake Victoria called Mfangano Island. And here we've partnered with Google to start the project, and later with UCSF and the KEMRI, Kenyan Medical Research Institute, to offer the microclinic model for HIV/AIDS positive patients, but also very importantly, their friends and family members around them. Lastly, we've done some work in India also on the issue of diabetes. So as you can see, we've worked in very different places all around the world in different languages and cultural contexts and different levels of development. And Jennifer had asked me to talk about some of the challenges that we faced in developing successful and innovative programs, but really also in terms of growing the organization itself. I think the challenges that we faced are probably challenges that all companies, all organizations face, but I do think that they're particularly acute in the nonprofit sector. In the private sector, if you have a great idea and you're able to get investments, you can sort of use that funding to build your team, to prove your model, and to go to scale. But in the nonprofit sector, I think as Jonathan alluded to earlier this morning, you're sort of expected to build your team, prove your model, and start to go to scale in order to get access to larger amounts of funding. So it's a sort of strange chicken and the egg problem. And in that process, when I was thinking about what to talk about today, I think it really boils down to these three specific challenges that we face and the lessons that we learn dealing with each of them. The three challenges are, number one, building a very strong team, because you can't have great programs if you don't have the people to run them. Number two is proving our model. There are lots of health organizations out there working internationally and in the United States. Why is it that someone should invest in the microclinic model? Why does our model matter? Why is it important? We needed to prove this. And thirdly, once we had those two pieces in place, how do we go to scale and do it in a sustainable way? Our mission as an organization is to revolutionize how epidemics are dealt with. It's not to do that by sending armies and armies of people out to lots of different sites and running these programs for a 2-year grant period. It's really to make it a sustainable solution embedded within a health system. So let's start with the first challenge that we faced, building a team. I think it's really critical to do good work to have a team in place to do it. We have a lot of all-stars at MCI. I'm really lucky to get to work with all sorts of very humble, but also very, very incredible people. We have a Rhodes Scholar, a Marshall Scholar. Our general counsel is from Harvard Law School. She came from one of New York City's top law firms. Our VP of Finance came from a Big 5 accounting firm. We have staff that came to us from the World Bank, the UN. Our researchers are all in fancy posts at Harvards and Berkeleys and et cetera, et cetera. But how did we get these great people to come to our organization? Well, we at MCI have, I think, which is a very innovative work culture. And the culture that we present has been able to attract the best of the best and to retain them. And how do we do this? We have a set of what we call happiness policies. So we sat down as a team and we thought about if we could all design our most ideal dream job, what would that look like? What would it make us happy to come to work and be a part of? We came up with a number of things, and I'll share them with you. These are all real-life policies that we implement. So that's what we did. We came up with these happiness policies. An example of a happiness policy is, number one, we don't track vacation. So we have an unlimited vacation policy. This might sound a little bit trivial, but it's actually not. There's a study that was done by the American Psychological Association recently to see why Americans stayed at their job and what they valued most. The answer, surprisingly, had nothing to do with salary. It was if people found their work enjoyable and if their work fit with other aspects of their life. So working in global health is not easy. You usually travel a lot. You usually travel pretty far. It can be tiring. Working in any field can be tiring, but I think particularly in global health, there are a set of challenges that make it very hard to have a family and to have a balanced life and to be able to attend to different areas of your life. So this unlimited vacation policy allows us to trust our staff and say, okay, you do your job, you do it well, and you take the time off that you need. And it's been a really key ingredient for us at MCI. Another example of one of our happiness policies is that we don't track hours at all or where people work from. So we don't say you need to come to work around 9 and stay till 6 or 7 and here's our office. People can work any time of day, any day of the week, from anywhere that they like. The only requirement is that they do their work well and they do it on time. And if they don't, they leave because they're not a good fit for our organization, and we've actually very rarely had to ask people not to stay with us. So this has been very effective in giving people that flexibility to do their work in a way that makes the most sense for them. We have a VP actually who she really is not a morning person, and if she needs to talk to a donor or something, she's there, but she does a majority of her work between 6 p.m. and 1 a.m. Doesn't work for me at all, but it works for her and she's quite effective. Another example of our happiness policies is that we have happiness events. So once a month, we take the staff and they leave work. It's always doing kind of the more traditional work hours, and we just do something fun. We might go on a hike, we might go out to lunch at a new restaurant together, nothing hugely difficult to plan, just a simple activity that we get to spend time together. And actually some of our best ideas and some of our greatest internal innovations have come out of our happiness events. It's when you give your staff that time to just chit-chat about their project and they're not working on a report or trying to finish a study or whatever, that they can actually reflect and talk in a more casual environment about the work at hand. So our overall philosophy is really to invest in our people and not so much in our overhead. This keeps our donors happy, but it also allows us to really put people at the forefront of what we're doing. I'll give you one specific example of this. We share our headquarters office with another company. So our office space is available to us a few days a week and available, that's a microfinance company, to the folks we share with. This really gives our staff a real reason to work remotely and not feel the pressure that they have to come in and be in the office at 9. So if someone has a child who's sick that day, no one even has to know about it or care. They can attend to that child, they do their work when they need to do it, and it's done. It's not an issue. This office share allows us to cut a lot of our operating expenses in half. Our rent is cut in half. Our utilities, print, fax, all that good stuff that no donor likes to pay for, the costs are basically halved. The second challenge that we faced was proving our model. Again, I said, what's our value add in global health? We spent the first few years of MCI running randomized controlled trials and cohort studies. So we're not a huge organization, but we were able to do very sophisticated RCTs, 2- and 3-armed RCTs, and we did this by partnering with various academic universities. Our director of epidemiology is on faculty at the Harvard School of Public Health. We also work with researchers at UCSF, others from Columbia and Oxford. But really, I think as organizations, you have a lot of value to add in this space. So you need the evidence behind your model, but also most academics don't have the same level of field exposure that you might have running the program. So there's a great opportunity where the academics might be able to contribute their comparative advantage in advanced modeling and biostatistics, and you can contribute your on-the-ground field experience that actually makes the trial run. The third challenge that I mentioned that we face and are currently dealing with is to scale sustainably. So the lesson that we've learned in working on this is we really need to have this virtuous cycle between programs, research, and policy. So on the program side, we run our programs in the field. We always partner with local institutions, whether that's the Department of Health in the United States or the Ministry of Health internationally. The research side I just spoke on is that we do clinical trials to test the health outcomes of our model. And the policy side is where we can take our programmatic experience and we can combine that with our evidence base and share it with policymakers to better inform decisions and allow the model to work at scale. This allows us to do this bottom-up policy making. So instead of someone in a capital saying, okay, we need to address diabetes and this is how we're going to do it and everyone now needs to follow this model, those policymakers may or may not have the realities of the local communities in mind when those decisions are being made sometimes. So being able to go and join those discussions and say, I have this experience in the field with real life communities, real life community health workers, but it's not just stories. Here's the hard evidence behind our work. Here are the results, has really helped us to engage in a more effective way in the policy side. So I think all the challenges I talked about and the lessons that we've learned from those challenges are really based on people. Again, I'll repeat, I don't think you can have very successful or innovative programs unless you have the people to do them. And working in a public health space, we obviously believe in preventative health. So we try to apply that preventative approach to our own staff in the way that we run our own organization. We think it's more cost-effective and makes more common sense to provide a workplace that people want to be in and they want to give their all. It definitely helps us prevent burnout. It prevents our staff turnover. And by spreading happiness, making happiness contagious in our workplace, we can make contagious health prevalent in the world. So thank you.